from India, evolution of management of Hangman structure from pedicle alignment to pedicle reformation. Pankaj Singh.
Thanks. I will be speaking on how we evolved in the management of Hangman's fracture. Initially, we used to do this pedicle alignment procedure, and later on, when we got complex cases, we started doing a pedicle reformation. So this is my cases, which I did from 2012 to 2018. So I will start with what is the fundamental is that we want to preserve motion at C1, C2 joints. So we usually don't include C1 in our repair of the Hangman's fracture. So first of all, what we normally do, that is pedicle realignment technique. And this was a patient, 50-year-old male, who presented to us with a history of fall of a bamboo on his neck. He was Asia B. This was his MRI, and you can see there's quad signal change, and this is the Hangman fracture. And you can also see there is a retrolisthesis of the C2 over C3, plus the fractures on both sides. What we do is we keep the patient in prone position, do exposure from C1 to C5, and we reduce this fracture by first positioning and then doing compression of the C2 lamina anteriorly. And sometimes we pull the C1 arch posteriorly also to do the reduction. Then we put under O-arm guidance, we put K-wires on both sides. You can see. This is on the other side, and then we tap and put screws, lateral mass screws. Then we do C3 for lateral mass screw and put a rod and do the correction. You can see there was retroangulation. What we did in this case was we did a distraction between C2 and C3 to correct the retroangulation. The patient improved to Asia C as there was cord signal change. You can see there was associated C1 3 points fracture. This is the anterior left, the posterior, and this is posterior right. And you can see a 6-7 month CT scan, there is callus formation, healing of the posterior arches on the both sides. So for a combined fracture, the basic treatment is of the Hangman fracture. And you can see the healing of the fracture. This is the fracture. This is the healed fracture. Then we got a patient who had he had a fall. He had a fight in the school, and he didn't tell his parents 6 months back. Later on, he started having neck pain and quadriparesis. So he came to us. We evaluated him. This was his X-ray. You can see there was a flexion extension X-ray. There was minimal reduction on the extension X-ray. So you can see this pedicle is reabsorbed, CT angio. You can see the reabsorbed pedicle. And this was the upper part of the C3, which was compressing the cord, which was leading to his quadriparesis. So we planned the surgery. This was the first time we were doing this. There was no pedicle, C2 pedicle. So we decided to put direct body screws in the C2. So we chose the entry point. You can see there was no pedicle. This is a diagrammatic representation. What we did was we put the body screws with bicortical purchase parallel to the inferior border of the C2. We did reduce it and did the pedicle reformation by putting bone chips from C2 posterior body up to the facet. So this was the intra-op photograph. You can see we have put bilateral C2 body screws. What we do is dissect the vertebral arteries laterally and directly go to the vertebral C2 body and put the screws. And 3-4 pedicle screws we used as we have to do a lot of correction and we didn't strength. That's why I didn't put lateral mass screws in these cases. And you can see the correction. And this was a post-op X-ray. This is the CT scan. And you can see the follow-up the pedicle has been reformed on both the sides. And the rotation of the neck was preserved in this case. Then we got another very complex case. He had this RTA 1 year back. He came to us with quadriparesis. At that time of first injury, he had left side this right side chest infection. He got amputation of the left upper limb. So we did the radiology. You can see this is the hangman fracture, and the C2 is coming up to the upper border of the C4 vertebra. We haven't seen a case like this. We thought that it is fused, but firstly we decided that we will go for a traction. And you can see also there is lateral displacement of the C2 over C3 also, anterior plus lateral. These are the angiograms. You can see 3D recon, and this was his MRI. You can see the kinked cord here, but with support he was able to walk. Power was 4-4. So we put him on traction, and we got a breakthrough. There was slight reduction from 4 to it came to C3. We again did soft tissue release and put him on traction. There was further reduction. Again, we did, after that, this was this. Then again, we went in anterior and this time posterior also, do soft tissue release and put him on traction. And we can see that it has come up to the upper border of the C3. So we decided that we will go with the standard posterior C2 body screws and 3 lateral, 4 pedicle screw. So this was this intra-arm images. You can see this is the normal. It is not coming fully back, so we pulled the C1 arch posteriorly. So you can see there is reduction. It is coming posterior. So now it was confirmed that we can be able to do the reduction posterior only. So what we did was put a C3 lateral, C4 pedicle screws and put a rod and hooked it anterior to the posterior C1 arch so that the C2 body doesn't move. And then we put the pedicle screws, this body screws, and put the rod. And same procedure we did on the opposite side. So we put 2 body screws, C2, 3 lateral, and 4 pedicle screw. And then we went interior, again anterior, and we put a bone graft and plate. So this was post-op X-ray. And you can see CT, post-op CT, lateral displacement auto got corrected. And these are the follow-up with pedicle reformation. This is the diagrammatic representation. Up to C4, it has displaced, lateral displacement. After traction, it has gone this much. After anterior release, this has gone slightly more up. After anterior and posterior release, it has gone up to the upper border. And this is intra-op. We have put a body screws, 3 lateral, 4 pedicle screw, and we have put the bone grafts from the body to the facet to form the pedicle. The post-op course was very stormy. He has at least it took the patient was admitted for around 2 months. He had 1, 2, 3, 4 surgeries. So it was around 720-degree approach. There was a chest infection, so we gradually weaned him off and put him on this stillate with oxygen for 7-8 days. Anesthetist helped a lot, and finally he was discharged. And you can see the preservation of rotation of this patient, and you can see good fusion, pedicle reformation, lateral displacement correction. So we published this. This is the first case report of pedicle reformation in world literature. And the take-home message is C1, C2 motion preservation should be tried. And big diameter screws can be put in C2 pedicle. And we can easily avoid, in these cases, the vertebral artery injury by dissecting and displacing them on the lateral side and putting direct body screws. Thank you.
Thank you very much. Может, у кого-то есть вопрос, доктор? I have one question for you. How often do you use hollow traction in C1, C2 dislocation?
In these hangman's fracture, we don't use this traction.
Thank you.
You are asking for AD, dislocation, congenital.
Hollow traction only for reposition of the dislocation C1, C2.
In the hangman's fracture, we don't use, but for fixed AD, we usually go from posterior. We don't use traction nowadays. we have a procedure called DCER. So we directly go from posterior, put spacers in C1, C2 joint and do reduction. We have our own technique. Our unit head, Dr. Chandra, has devised that, and we have published that in neurosurgery also. So we usually don't put patients on traction nowadays of AD with BI.
Thank you very much.
Excuse me, I have one more question. Hello, nice to see you again, a few months later. So it's a very, very nice talk. Thank you very much. And would you recommend, in case of the pedicle reconstruction, for how long time post-op you would recommend the collar for the patients?
3 months. The standard is 3 months. We put for 3 months.
For 3 months, yeah. Thank you.
Так,